Okay, perfect. So I thought today I'd cover a little bit about childhood transmission and COVID and the impacts on children, covering a little bit about the Omicron variant and what's going on right now in England and Scotland as well. So I'm going to start with some key concepts. I think the first question I'm going to ask is, if you look at this figure, which orange circle do you think is bigger? I think it's difficult for people to answer interactively here, but to me, the right one certainly looks bigger. But I hope that this will convince you that they're actually the same size. The reason I've put this up is this sort of thing was put up by John Howard, who also studies childhood transmission. And one of the things that he highlighted is that the impacts in children are often compared with impacts in adults, and they look very, very small by comparison. But when you consider the absolute impacts in children, they are significant, particularly when you compare COVID to other childhood illnesses. And he called this sort of optical illusion or a fallacy, where people often make comparisons between children and adults, which are flawed and, well, in my view, unacceptable, because we shouldn't expect the same consequences in children, and we shouldn't accept that children should have to have impacts that are comparable to adults before we act. So a few concepts when we talk about childhood transmission. There are three things that affect, impact on a person. So, or whether a person gets infected. One is susceptibility. What is your intrinsic, I guess, biological susceptibility to getting infected if you're exposed to infection? The second was exposure. How likely are you to get exposed? How many people do you come into contact with, and how likely are they to get exposed? And transmissibility. Once you get exposed, how likely are you to transmit to other people? When we look at transmission in the real world, often we're looking at these three things together. And the reason that I've separated them out in this way was there was a sort of thinking early on during the pandemic that children were less susceptible, so less likely to get infected if exposed. But a lot of this didn't account for the fact that actually children had huge amounts of exposure, far more than most adults did, because they came into contact with so many other children in school. So even if your susceptibility is lower, which is actually not the case in children now that we have less flawed studies, the level of exposure that you have each day can hugely affect your chance of getting infected. So studying this in children has been very, very challenging, because children often have mild or asymptomatic infection. So when you look at routine testing, which is what, for example, Public Health England and Public Health Scotland does, often asymptomatic cases aren't captured. They are captured better now because we have rapid testing, but early on in the pandemic, they weren't captured at all. And this means that children are often not identified as index cases, and often infection is only picked up, for example, even in schools or households, when an adult like a teacher or a staff member or someone at home got infected. So often children were not tagged as being sort of these intermediates of transmission early on. And false negatives on routine tests are also high. I mean, those of us with young children can talk about how difficult it is to do a swab on a young child. And there is good data now that suggests that PCRs are more likely to be negative in children. Seroprevalence data is also not reliable in children, because children generally tend to have lower levels of antibodies than adults and tend to serorevert. That means become seronegative after they are infected much earlier than adults do. So this means that many studies that rely on these methods that were done originally to indicate that children were not likely to get infected or transmit were quite flawed. So this is data from England, from the Office for National Statistics, which is not biased, because this is based on community surveillance. So this is a study where essentially random households are sampled regardless of whether children have symptoms or not, and tests are done in different age groups to see how many people are positive. And this is the first year of the pandemic. And what you see is that in primary and secondary school children, that's the red and pink line, you see that infection follows very closely school openings and even half term. I mean, you see very clear dips in half term infection, not only in the children groups, but also followed by other adult groups. And that's what we see again and again, that children often sort of determine the infection rates in the community as schools open and close. And we see in December, this is December 2020, when we went into lockdown and schools closed at the end of term, the highest infection rates were actually in secondary school age children at that time. And you can see that they peaked before rates peaked in other age groups. So, they were sort of the determining factor of infections in the rest of the community. And, it's very, very clear looking at this that infection rates in secondary school children were extremely high throughout the autumn of 2020. But if you look at our routine surveillance, which is from Public Health England, very much like Public Health Scotland, children are down here. So the equivalent age group is this gray line. And you don't see that trend. You don't see that they had the highest levels of infections and were actually driving infections in the community, which is a problem with using symptom-based data, because it will miss the vast majority of infections in children. So, but unfortunately, that has not stopped researchers from saying children are far less likely to get infected, despite knowing that these data are flawed. The ONS data always showed that children, when schools were open, had some of the highest rates of infection, even before vaccination. So these were studies that looked at the relationship in different countries between school openings and closures. What impact did it have on the R rate, and compared to many, many different interventions. And they showed that closure of educational institutions was the second most effective intervention in reducing R rate, or the rate of growth of the pandemic. And when they looked at primary and secondary schools, the impact of primary school closures and secondary school closures was quite comparable. So it wasn't very different. There were many other studies that showed this, and I'm not going to go through them. But this is our own data from England, where the ONS survey, which did household contact study modeling, showed that children were far more likely to bring in infection into a household than adults, between 2 to 7 times more likely than adults, depending on their age group, and 2 times more likely to transmit to household members than adults. So children certainly do get infected, probably because of mass exposure in school. So, it determined that the relatively susceptibility was lower, but that because of exposure, they were more likely to get infected and more likely to bring infection into households and infect to members of the household. And if you look at less biased studies, so we know that children, for example, cases based on symptoms will be underestimated because children are more likely to be asymptomatic. But what if we look at their parents or their teachers? And there are many studies across the globe that have now looked at are parents at greater risk of being infected? And they all come to the same conclusion. So this is a huge study of millions of people across the UK, which showed that parents had a higher risk of infection. They also had a higher risk of hospital admission, but it didn't translate to a greater risk of death. That part is quite hard to make any sort of claim or interpretation about, because it looks like non-COVID deaths, so deaths from other causes in parents, were far, far lower than non-parents. So some might argue that for some reason, parents are healthier than non-parents. I don't know exactly why. But it looks like there was another factor that was confounding the association, but certainly parents were more likely to get infected and hospitalized. And this is a study from Denmark that once again looked at the risk of infection in adults living in households with children. And the risk of infection goes up depending on the number of children you have in the household, and also the age of the child that you have in the household. So if you have a 6+ child in the household, you are at greater risk than your counterparts of the same age. And if you have more children in the household, you are at greater risk as well. And this is a very, very key study that came out of the US on about 500,000 people, where they had some sort of a COVID symptom tracker, very much like the Zoe one that we have here. And they essentially looked at the risk of parents of children. So this is the risk of parents of children who were in person, full-time in-person schooling and part-time in-person schooling. And not only did it show that parents of children had a higher risk, whatever age group their children were in, But it also showed that mitigations in schools reduce that risk. So this is a number of mitigations present in schools, and the ones they studied were these ones. So one of the commonest ones were, student masking, teacher masking, and then, you go on to the other mitigations. And it showed this sort of dose response, showing that if you had a few mitigations, the risk was slightly reduced. And as you move to having, above 7 mitigations, the risk of parents, again, this is of children, was reduced to baseline, essentially their counterparts who were not living with children in their households. So not only did this show that parents are at higher risk and infection in children translates to, infection in households, but also showed that we can prevent that by putting in mitigations in schools, but we need to put in multi-layered mitigations, and single mitigations in themselves are not sufficient. So just looking at the current, moving to where we are right now. So the current situation in Scotland, we've seen very, very high levels of infection in children over the Omicron wave, unfortunately. And the fact that children are the most unvaccinated population hasn't helped this. What we're seeing right now in Scotland, at least, appears to be that infection rates in children are dropping. But, as we see, it looks like there has been spread to other age groups, and infections in other age groups, particularly the most vulnerable age groups, is rising. And that might explain why daily hospitalizations have actually plateaued, and we're beginning to see early rises in the number of people in hospital in Scotland, because this is the age group that matters most in terms of hospitalizations. And if you want to look at the Office for National Statistics data, which is not symptom-based testing, so the previous one was Public Health Scotland data. So this is data from random sampling in the population. It looks like 10% of young children currently have prevalent infection. So that's 1 in 10 children in the community. If you tested them, they would be PCR positive. And if you look at older children, it's around 7%. So that's 1 in 14. So, on average, that's between 2 to 3 children per classroom are PCR positive. And that's really concerning, and also shows how much we miss in children with routine testing, because you can see actually infections in children are higher than all other age groups right now. And, this is looking at Scottish data, which is actually quite similar to data from England. But, I found this particularly shocking. This is data on antibodies, so model data on the seroprevalence of children, whether they have antibodies or not. And it shows that in the age group 8 to 11-year-old, which we know is unvaccinated, almost all of them are unvaccinated, the antibody prevalence is 73%. This means that at minimum, 73% of children have been exposed to infection, not vaccination, infection. And I personally think that's a huge failure. And remember that a lot of children, immunity wanes, they don't fully seroconvert. So the actual level of exposure is going to be higher than this. And, if you look at it, there's been a substantial increase during the Omicron wave. So it also shows how much mass infection of children has happened during the Omicron wave. The 12 to 15-year-old data shows 93%, but of course, some of this will be because of vaccination. So, we can't really extrapolate to how much was because of infection there. In the midst of all this, we are seeing a new variant, a new, more transmissible variant that's growing. We know that it's growing. It's been, become dominant in Northern Ireland and is driving growth of the pandemic. In Northern Ireland, I think 1 in 13 people are currently infected. So infection rates are extremely high. We should expect to see BA2 become dominant in other nations as well. In Scotland, it's at about 22% currently. So this is BA1 and this is BA2. So it's about 0.9 out of 4.1% totally. But it will rise to dominance. And as it rises, because it's more transmissible and seems to transmit faster, we would expect potentially to see the growth of the pandemic either resume or at least the R increase to above what it was with the previous Omicron variant. And in terms of vaccine uptake, this is the thing. We really haven't prioritized children. Scotland has done much better than England, where vaccine rates are even lower. But, particularly with Omicron, this is now a 3-dose vaccine. And, even if you look at 2 doses in 12 to 15-year-olds, only 40% have received 2 doses. And in terms of 3 doses, it's very, very low. So protection against transmission and infection in children will still be quite poor. And part of this is down to the huge delays in recommending vaccination by JCVI, which we're seeing in 5 to 11-year-olds as well, which is a population that remains unvaccinated. What's really worrying is, despite all the rhetoric about Omicron being mild, here's a study by Imperial that has been shared by SAGE as well, that shows that in children under 10 years of age, Omicron is not milder than Delta in terms of hospitalization. So the risk of hospitalization with Omicron and Delta remains the same, but in adults, it's considerably reduced. And this is really concerning because Omicron has led to a huge increase in exposure of children. So we've seen many more children get infected, but the case hospitalization ratio, so the proportion of children who get hospitalized out of the cases, remains the same for children, not for adults. So we've seen an increase in impact in children because of Omicron. And this thing is what worries me the most. All of this is translating to far more long COVID for children. So this is the Office for National Statistics survey in the UK on people reporting whether they have persistent symptoms lasting for 28 days or more. And we've seen huge rises in children, not so much in other age groups because vaccines do provide protection against long COVID, but huge increase in children. In children, long COVID rates have tripled in a matter of 4 months. And I want to point out that these are infections up to November, which means that we haven't seen the impact of the Omicron wave yet on these because, obviously it takes 4 weeks to collect those data, another month to sort of analyze and release them. So I don't know what it's going to mean for long COVID, but we cannot take exposure to children lightly. And it's very likely that early vaccination of children would have at least blunted some of these increases as they seem to have done in other age groups. But for some reason, we decided it wasn't worth vaccinating children early on. So hospitalizations and deaths, and here I'm going to refer you back to that early 2 orange circle plot because I'm going to now compare COVID impacts with those from other diseases, which is far more appropriate than comparing COVID impacts in children to adults. We've had 19,000 hospitalizations with COVID in 0 to 17-year-olds until now. Yes, all of these will not have COVID as a primary cause, but if you consider even if half of them or 60% of them have COVID as a primary cause, that's a huge number. In terms of deaths, we've had about 98 deaths involving COVID, so COVID on the death certificate in 0 to 19-year-olds. And if you compare this to annual deaths from COVID in 2021 to deaths from other diseases before COVID in 2019, you will find that these deaths vastly exceed those from all other childhood illnesses. And this is data from the CDC that shows very similar for 5 to 11-year-olds that COVID impacts, even in terms of deaths, while we hear that they're not severe, actually exceed the impacts for other infectious diseases. And this is even before vaccination. And we vaccinate for all these diseases. So why don't we for COVID? I think a lot of the policy in England, and I think partially in Scotland as well, has focused on children being, part of some sort of bubble and outside of society. But children are impacted by what's happening around them. And these are estimates from the Imperial Orphanhood calculator that shows that about 12,000 children have been orphaned by the death of one or both parents because of COVID. And that's a huge impact that we never talk about. So the impacts on children of COVID are significant, and one might argue they're even greater than many other infectious diseases. There's long COVID, which I've talked about. Educational disruption is a huge issue. I mean, we had 400,000 children in the UK off COVID towards the end of January. Things like vaccines and mitigations could hugely reduce that. Hospitalization and deaths are significant and actually higher than other infectious diseases that we vaccinate for, and the impacts on family members, orphanhood, as well as long COVID in the family. So for all these reasons, vaccines and mitigations are vitally important. And I always put the slide up because it's just sort of shows that there are different layers of mitigations, and every single layer helps. And one mitigation by itself against the community rates of 1 in 10 children infected is not going to be sufficient. So you have to keep background transmission low, but also have multiple layers, which is high grade face masks, ventilation, and asymptomatic testing and vaccination, all those other things.